Hello, everyone. Welcome to our panel discussion, Pandemic, Endemic, the state of COVID and what we've learned. Today, we are going to explore the state of COVID-19, how we got here, and what we learned in the process. My name is Dr. Nicole Rochester. I am the IDF's medical advisor for health equity. I am a pediatrician. I am a professional health advocate and the CEO of Your GPS Doc, which is an innovative organization that focuses on helping individuals and their family caregivers understand and navigate the complicated healthcare system. I am pleased to be the moderator for today's session, and joining me are Dr. Mary Elizabeth Younger and Dr. Adi Gunlapalli. Dr. Elizabeth Younger is an assistant professor of pediatrics at Johns Hopkins University and works as a nurse practitioner at Johns Hopkins Hospital. She holds an undergraduate degree from the University of Virginia, a master's degree from New York University, and a PhD from the University of Virginia. Dr. Younger's research has focused on primary and secondary immunodeficiencies, immunoglobulin replacement therapy, and psychosocial issues faced by people with immunodeficiencies. Dr. Younger serves on IDF's Nurse Advisory Committee, is a staunch advocate for patients' rights, and is the winner of the IDF Art of Nursing Award presented at this very conference a few years ago in 2017. I'm also honored to be joined by Dr. Adi Gunlapalli. Dr. Gunlapalli is a physician and informatician who currently serves as the Chief Public Health Informatics Officer at the Center for Surveillance, Epidemiology, and Laboratory Services in the Centers for Disease Control and Prevention, or what we know as the CDC. In this role, he has been actively involved in the national response to COVID-19 with regard to data and analytics. Prior to joining the CDC, Dr. Gunlapalli was a professor of medicine at the University of Utah School of Medicine. With training and experience in both infectious diseases and clinical and laboratory immunology from 2016 to 2019, from 2006 to 2019, Dr. Gunlapalli provided both outpatient and inpatient consultations for patients with primary and secondary immune deficiencies in the Intermountain West. He had also been actively involved with IDF for patient outreach and research activities while at the University of Utah. Welcome, Drs. Younger and Gunlapalli. It's a pleasure to be here with you and spend this time together. So I want to start out by just giving a little bit of context. The title of our session is Pandemic, Endemic, the state of COVID and what we've learned. And I know that there's often a lot of confusion around these terms. So we're going to start with just a little bit of level setting. What is the definition, or what are the differences between a pandemic and an endemic and maybe even an epidemic? So when we talk about an endemic, what we're talking about is a baseline level of a particular disease in a community or in a geographic area. It's the level of that disease that's present in the background at all times. Now, when there's a sudden increase or surge in the number of cases of a particular disease above and beyond what we would expect, then that is typically referred to as an epidemic. And then when that epidemic spreads across geographic barriers, across countries and continents where you have global impact, then that is the definition of a pandemic. And you may recall that on March 11th, 2020, the World Health Organization declared COVID-19 a global pandemic. So there's a little bit of controversy now where we've heard, different individuals and politicians talk about whether we are now in an endemic phase as it relates to COVID-19. And what we know for sure is that regardless of the definition of pandemic or endemic, the impact of COVID-19 is a little bit different among those who have primary and secondary immunodeficiencies. And so hence the purpose of our panel today. So I'd like to start by learning, or having the audience learn a little bit about each of you, the roles that you have each played in relation to COVID-19. Are you caring for patients? Are you creating protocols? Are you conducting research? And so we'll start with you, Dr. Younger. Why don't you give us a little bit of background about the activities that you have been involved in during the COVID-19, I'll say pandemic?
Pandemic, endemic, it's a lot about words. And there's a lot of words that need to be understood and clarified. But basically, for the past 2.5 years, like everyone, the world has been COVID. And people get information from a variety of sources, and the information is many times, oftentimes contradictory, and people are not sure what they should be doing, what they should not be doing. And um, basically, my role in the past 2.5 years, it has been talking to my patients and talking my patients through the situation, and sometimes talking them off the ledge. I actually did a talk at the Academy meeting earlier this year, and I had a wonderful picture of this man in a business suit, and you saw his wingtip shoes leaning over the edge of an apartment building in New York City and looking down. And that was the slide that defined things for me and for my patients. And trying to get through all of the things that were contradictory, and what indeed they should be doing. At Johns Hopkins, we have an extraordinarily large population of immunodeficient patients. I have 500 patients who have antibody deficiencies and are on immunoglobulin. And then there's a whole subset of people with other kinds of immunodeficiencies not affecting antibody disorders. And each of those people, in the context of their condition and the context of their life and the context of the other presentations they have, other illnesses they have, other diseases they have, they don't all get the same answer. And I think that was one of the important things for the past 2.5 years, is that I've cut through what's the right answer for each individual, because one size absolutely does not fit all. And that's what was, every time I would be sitting down watching nightly news before Jeopardy, and I would watch something on the news, and I would know that my phone was going to be ringing off the hook in the morning, because somebody said something about, well, everyone should have X, or all immunocompromised patients should have Y. And I knew that for the next 3 hours, starting at 7:30 in the morning, my phone was going to go off the hook, and I was going to be, again, talking people off of the ledge and trying to give them context and reality. So that's been life for 2.5 years. And I truly do look forward to going back to quote unquote normal and being live and in person at this meeting 2 years hence.
Awesome. Thank you so much, Dr. Younger. I appreciate that insight and hearing more about your experiences with patients. So what about you, Dr. Gundlapalli? What has been your involvement and activities over the last couple of years?
Thank you, and good morning, everyone. It's a pleasure to be here and really appreciate being invited. At CDC, for the past 3 years, I've not been directly caring for patients. I've been involved with the national response to COVID at CDC and have contributed to public health and clinical guidance for diagnosing and managing COVID-19 patients. And our teams have been working on analyses of surveillance data and healthcare data. So really seeing it from a national level. It's been quite humbling. Several of my former patients have called me early and during the pandemic to discuss their concerns, and so it's been a few of them, and so I've really been keeping up with that. And just recently, my colleagues and I at CDC have published a systematic review of health outcomes in COVID health outcomes in patients with PI. So I had to go through a lot of literature to see what's going on. So thank you.
Thank you so much, Dr. Gundlapalli. We appreciate both of your efforts. Certainly, it's important to have the clinical aspect with the patient care, and we also need individuals helping out with the guidelines and the surveillance. So I appreciate your insight on that. So what are the questions that you all are getting? Dr. Younger, you mentioned that you often hear from patients after some of the news stories, after some of the release of the guidelines. And Dr. Gundlapalli, I'm sure that you mentioned also you have former patients reaching out to you. I'm a pediatrician, don't practice medicine currently, but I have both former patients and parents, as well as my own family members and friends who initially reached out on a regular basis regarding COVID-19. So we know that all of us in the medical profession have been somewhat bombarded over the last few years with, people that are appropriately worried, people that are wanting to verify the information that they're hearing. So I'm curious to know now, we're in the fall of 2022, and while things are better, COVID-19 is still here. And so what are some of the common questions that you're getting now with regard to COVID-19? And this time we'll start with you, Dr. Gunlapalli.
Thank you. Yeah, the questions and concerns regarding COVID keep evolving, right? And currently, I think there's 3 or 4 major areas. One is really the variants, right? I mean, we're all learning the Greek alphabet all over again now, and everybody knows all these dots and etc. So the variants and how they're evolving, and whether they'll escape either infection from prior immunity from prior infection or from vaccine. The other one is about the COVID vaccines. As you know, the government just recently approved, and the companies released the bivalent vaccines, meaning that has both the ancestral strain and also the current Omicron strain, not the exact sublineage, but the previous one that was there. So that has been a big push for the government, and we do get questions. And the answer is yes, you should please get it if you're eligible. And yes, you can get it along with the flu shot. So I got mine on this arm and that arm. Yes, it hurts. So you have to just be careful. The other important point is that even though, the country has sort of learned how to live with COVID, there's still 300 to 400 individuals per day dying of COVID. And that is a concern. And those individuals, unfortunately, are the most vulnerable, right? These are the elderly, those who have more than 2 or 3 comorbidities. And it's really unfortunate that we're not able to save them, even with vaccine and what we've learned. So those are the ones. The other big deal is the evolving landscape with regard to the variants and what treatments and prophylaxis can you use, right? I mean, you've heard about Evusheld is the only pre-exposure prophylaxis, but now some of the sub-variants or sub-lineages will not be covered by that. So gosh, how do you keep up with it? And then that, the tongue-twisting names of all the monoclonal antibodies that were released and the antiviral medications, and government and FDA specifically, and CDC and NIH keeping track of which medicine, which variant, and what can you use at that time. So that we keep, getting a lot of questions on. As you know, primarily Omicron variants and sublineages are circulating in the US, so BA 4.5 and increasingly BA 4.6 and BA 2.75 is not yet that prevalent in the United States, but CDC is watching that from the rest of the world. So it's really about the variants, the vaccines, why death's still occurring, and then, gosh, which medicines can you use against which variant? So it's really a gamut for us. Thank you. Over.
Yeah, thank you for that, Dr. Gunlapalli. That's a lot, and those are some of the questions that I'm hearing as well. What about you, Dr. Young? What kind of questions are your patients asking you now in this phase of the pandemic?
So I would reiterate what Dr. Gunlapalli just said. If people want to know, should I get this vaccine? What can I do? What can I not do? Can I go to this wedding? Can I fly to California? This is a once in a lifetime opportunity for me to go to X, Y, or Z. Can I go to X, Y, or Z? My husband's family's not vaccinated. Can they come? My family's vaccinated. I know they can come. The important thing I think that needs to be clarified is that everyone's not the same, and the same answer doesn't work for everyone. And that's the biggest problem, I think, for our patient population. The words immunocompromised is not a synonym for immunodeficient, is not a synonym for immunosuppressed. anybody can have a compromised immune system. It's how that system is compromised that's going to affect the answers that you get. Everybody wanted Evusheld when it came out. Evusheld was the magic bullet. Obviously the drug company thought they were going to make gajillions of dollars and they were selling it and everybody was going to get it. Well, initially the allocation per state was extraordinarily small. And people were like, okay, well, who should get this drug in very short supply? How are we going to maximize the effect of this drug? And at Johns Hopkins, we have a standing ethics committee just to address this sort of issue when things like this come up. Years ago, when there was a huge shortage of immunoglobulin, that committee sat down and came up with a criteria list of who gets the immunoglobulin. At that point in time, obviously the immunodeficient were right at the head of that list. When we talked about Evusheld, interestingly, the immunodeficient patients, my patients, didn't even make the top 10 on that list because my patients had antibodies. My patients, about 75% of the people I vaccinated made tremendous antibody responses to vaccine. And I knew that they were protected on some level. The people who got Evusheld at Johns Hopkins were the people who made no antibody in response to vaccine. And those were the, wait for it, immunosuppressed people, the people on drugs, people who had transplants, mostly solid organ transplant patients, patients who'd gotten new livers, new lungs, new kidneys, and the drugs that you use for those to prevent rejection caused no or little response to vaccines. Those people were at the top of the list for Evusheld. It wasn't the oncology patients, it wasn't my immunodeficient patients. And my immunodeficient patients called up, well, why can't I get Evusheld? My primary care doctor says I should get Evusheld. And I said, I have the numbers right here. I looked at your antibodies. Your antibodies are so high in response to vaccine that they can't even be measured. They're greater than 150 units, or they're greater than, or they're whatever. And it was very hard for people to hear that. They were getting advice from CNN and NBC News and the New York Times and their primary care provider, their specialty care provider, and all that advice sometimes doesn't mesh. So the questions my people were asking were, some people had had 4 and 5 vaccines. And I'm like, why? Nobody looked at your antibody response. How do we know that you needed 4 or 5 vaccines? And does anybody need 4 or 5 vaccines? Because I can't find any data suggesting that anybody is saying that. So every patient needed that unique advice that pertained specifically to them. I didn't hand out global advice, and I couldn't, because every one of my people was different. And it was, and it remains an extraordinarily difficult thing to do. Right now, not only am I getting, should I get the bivalent vaccine, all my people want monkeypox as well. Like, no, you don't need it. And B, it's a live viral vaccine, so you really don't need it. But it's just those kinds of issues. And if I were on the other side of my desk as a patient, I can see exactly how I would be in a frenzy. I would be confused. I would want to do the best thing for me, what was going to be best for my family. And I totally get how patients are in a quandary and legitimately frenzied about what they should be doing and how they should protect themselves and how they should protect their family. And it's extraordinarily difficult because what I tell you on Tuesday may change on Wednesday.
Yeah.
I mean, the first monoclonal infusions that we were giving, they were through the state of Maryland, we ordered them through the Maryland Health Department. They were actually giving them at the Baltimore Convention Center. And on a Friday afternoon at 4 o'clock, the announcement came out that these aren't effective anymore. We're not giving them. And I had people scheduled to come in on Saturday, Sunday, and Monday. Their infusions were canceled because Friday afternoon at 3:30, the monoclonals that we were giving weren't effective anymore. That was really hard for people to hear. And I called people
Yeah,
and said, well, guess what?
I appreciate you sharing that side of it because, you know, the fact that we have both of you here, it really demonstrates kind of this tension, right? When we're in the middle of a global pandemic, we're moving out maybe to endemic stage, but the point is like we have to consider the public health element of a global pandemic and population health measures and things like that, and we have to ensure that there are messages that are given, you know, to large audiences of people. But to your point, Dr. Younger, this is not a cookie cutter approach, particularly for individuals who have primary immunodeficiency. And so it just reiterates the importance of not only listening to the larger messages, but always getting the information from your actual provider. So I appreciate that perspective, and both are important, but we have to really underscore the importance of individuals with underlying illnesses, making sure that the guidance that you receive is very specific and directed around your condition and just some of the tensions that arise from that. So Dr. Gulapalli, you mentioned one of the studies that recently came out. There was another study that came out by the CDC that highlighted the fact that among US patients hospitalized with COVID-19, those who are immunocompromised accounted for a very significantly, disproportionately high percentage of hospitalizations. So 12% of all adults hospitalized with COVID were immunocompromised, and that's disproportionate to their share of the population, which is only 2.7%. In the study, it was determined that these individuals also had higher risk of severe outcomes like hospitalization and death, ICU hospitalization, and that was regardless of vaccination status. So again, regardless of what's being said on the news, it's clear that the pandemic is nowhere near over for those with immunodeficiency, despite the fact that many in our country and across the world have moved on, so to speak. So I'd like to ask each of you, what recommendations are you giving to PI patients and caregivers as they navigate this stage? And Dr. Younger, we'll start with you. I know you already shared you get questions about practical things like weddings and airfare or air travel rather. So what is the advice that you're giving to PI patients and their families?
So if I could back up a spec, so you need to define immunocompromised. When you talk about those outcomes in that study, that involves anyone who's got some kind of hit to their immune system. That is not all immunodeficient patients, and that's really, really important. The Clinical Immunology Society is actually putting together a study, and they wanted 1,000 patients. And I'll tell you that Johns Hopkins, we contributed data for 200 of our patients toward that 1,000. And that was patients specifically with immunodeficiencies. And they were looking at vaccine responses. So I will tell you that of my 500 patients on immunoglobulin therapy, I had one single death from COVID. And it was a lady who had other comorbidities. She had significant illness of another system outside of her immunodeficiency. I hospitalized fewer than 10 patients. And of those 10 patients, every single one of them had a comorbidity. 6 of them had a cancer diagnosis. So not only were they immunodeficient, they were also on chemotherapy that affected other arms of their immune system. So for immunodeficient patients to look at those data and say, oh my God, I'm immunocompromised, I'm going to get terrible disease, I'm going to go into the hospital, I'm going to die, is not true. And the immunodeficient population needs to understand that. And it's not even the entire immunodeficient population. Depends on what kind of immunodeficiency you have. For example, if you have chronic granulomatous disease, a disease that affects the way white blood cells respond to certain bacteria and certain viruses, they don't have a problem with COVID. Patients with complement deficiencies who are very susceptible to infections with encapsulated bacteria, they don't have a a problem with COVID. And it's really, really important to understand what your immunodeficiency is and whether that puts you at an extraordinary risk or a relatively mild risk. It's very, very important to understand. So if I can get off my soapbox and go back to your
Yeah, no, thanks for clarifying that.
what we're
Yes.
telling patients, and basically we're talking patients through things. I've looked at every single patient I've vaccinated. I have antibody levels on whether they responded to the vaccine or not. And if I have a robust antibody response, I am relatively confident that should that patient get COVID, it's going to be a relatively mild illness. And we have not been prescribing a lot of antivirals. We've not been prescribing a lot of monoclonal infusions. Basically, we've prescribed symptomatic treatment for the vast majority of our people. If you're a little feverish, a little Tylenol, a little Motrin. You're a little bit achy, a hot shower, a hot bath definitely does it. Lying on the sofa, curled up under the Afghan, as I say, reading a trashy novel or binge watching something with a pitcher of orange juice on the coffee table is probably a really good way to get through this relatively minor illness. Not for everyone, but for patients that I know are vaccinated, that I know have good antibody levels, that don't have significant other comorbidity. And I have that conversation multiple times a day. Everybody wants the new medicine or the new monoclonal, or what's the name of it again? I don't know. What's the name of the one today? But you've got to consider every patient with regard to what their immunodeficiency is, what their comorbidities are, what you're treating them with, what you're treating them for. As I said, I can't practice medicine based on what CNN tells me.
Absolutely. Thank you for that. Appreciate it. What about you, Dr. Gundlapalli? I know you're not having direct patient contact, but I'm sure that you have encounters with patients and family members and maybe even your own friends and family members. So what advice would you give to the PI community right now regarding navigating COVID-19?
Thank you. And I resonate with Dr. Younger, I think, who said it very well. I think the sort of where we are in the pandemic, we're thinking about individual and family doing their own risk assessment, right? I mean, it's really that it comes down to that. I mean, can you travel? Can you do this? Is your family, safe? And where are you going in terms of that? So I think, and you know this, and Dr. Younger knows this very well, and we know PI patients of all ages and those caring for PI patients have always maintained a higher level of alert for all types of infections, right? Especially for respiratory, be it the annual influenza season or pneumonia or illnesses circulating in their communities, right? We've both, Dr. Younger and I probably have both got calls on something circulating and say, hey, what's going on and all that. So in that way, I think with the uncertainty and yes, we've got COVID in sort of a vaccine preventable stage, right? It's a vaccine preventable disease now because you can actually prevent it with a vaccine. But I think it all comes down to what is your individual risk assessment and making that along with you, your family, and your provider. Because, and to be frank with you, government cannot and is not able to provide a guidance for every single individual in the country, right? Because they are unique and we have to celebrate that uniqueness. But then being able to say, this is where we generally are, but please do. Right? And so just finally saying with that the article that we just published, we clearly make a note there saying, as mask mandates and community-wide use of masks and adherence to other mitigation measures decrease, an accurate assessment of risk is essential for patients with PI to help guide them, their families, and their healthcare providers. So take that, and I think Dr. Younger's advice about digest some of that and work with your providers and make your own self-assessments. So that's what I would say too. Thank you.
Thank you. Thank you both. That's great advice. Yeah, I mean, ultimately it comes down to having access to accurate information, being able to digest that information, discussing it with your provider provider so that you're making sure that your unique aspects are being incorporated and that you're getting advice that is unique to you and specific to you. And then, like you said, Dr. Gundlapalli, ultimately it's a personal risk and a family risk. And so, as medical professionals, we can provide the advice based on the evidence, but ultimately each individual has their own degree of risk tolerance that also comes into play, which really kind of goes back to what I'm seeing as a theme for today's conversation, which is really centering around the fact that there is no cookie cutter approach. I mean, there's guidance, there's evidence, and all of that is extremely important. And then ultimately it comes down to your individual, your desires, your concerns, and your risk tolerance, and that of your family as well. So I appreciate both of you weighing in on that. So I want to switch gears just for a moment and inject health equity into this conversation. We knew, I guess, within the first 6 months or so of the pandemic that not everyone was being impacted equally. And we've talked about the disproportionate impact on those with certain types of immune deficiency as an example. We also know that the COVID-19 pandemic has disproportionately impacted people of color, specifically African Americans, our Latinx and Indigenous populations. So based on your respective areas of expertise, what recommendations do you have for strategies to address what we continue to see as ongoing disparities as it relates to access to care, access to accurate information, as well as disparities in clinical outcomes? And we'll start with you, Dr. Gundlapalli.
Thank you. I think that's, gosh, it is challenging, right? I mean, this is an ongoing and important discussion regarding disparities at all levels. And what you mentioned, Dr. Rochester, is very important. And I'll go one step further. What about the intersectionality of race, ethnicity with disability status and with immune compromised status? Gosh, are there, patients of racial ethnic minorities who have immunocompromising conditions and, of course, PI and secondary immune deficiencies? How are they able to access? Are the providers they see, are they aware of what's going on, right? So it's at multiple levels. And unfortunately, there's no one magic wand type of answer to these longstanding challenges where we see conditions and diseases disproportionately affecting certain populations. What I would say personally is that all of us have a part to play in this. So increasing awareness, continuing to gather data to inform interventions and policy changes. And this is a priority for CDC. We've not always, thought of it that way, but CDC and COVID-19 response was a huge difference for us. We have a unit called Chief Health Equity Officer Unit in the COVID response. So every guidance, and by the way you put it, Dr. Rochester and Dr. Younger, was perfect. CDC issues guidance, not edicts, right? So you have to then take it from there and then say, so we cannot give edicts and laws, so we just say guidance or consideration. So it's a very politically correct term there. And we are moving also in that direction. I mean, there's enough data. We don't need data every time to know that there's disparities, right? We know it's there for 100 years and unfortunately. So what we're trying to do is move beyond that and see if we can address the drivers of health disparities. And we have that front and center. We may not always do a good job on that, but we're hoping to learn. And we're in huge listening session mode. So as you know, our teams listen to many, many societies. It's called listening sessions. So we don't talk much other than to say hello, and everybody gets to say what they want and we take notes. And please know they don't go into a vacuum. We do actually hear all of those. So thank you for addressing this very important topic. Over.
And I would echo that as well, but I also think it's a little bit about cognizance and awareness of who might be at risk and who might benefit from something extra. I know in Maryland, it's kind of an interesting state. It's a little state, but it covers the great spectrum. I mean, we have the Washington, D.C. suburbs. We actually have a lot of rural areas. We have the Bay Area, and there are a lot of very disparate places in the state of Maryland. It's not really as homogeneous as you would think. Maryland is. And when we were looking at county data for vaccine rates in counties, it was exactly what we would predict. That, this county is 86% vaccinated. This county is 34% vaccinated. Baltimore City was always among the worst vaccinated, but yet you cross the line into Baltimore County or into Anne Arundel County, the counties surrounding the city, and the rates went up much higher. So I think it's an awareness and a cognizance that's important, and putting the extra effort into getting to those populations. I know in Baltimore City, they called in community leaders, movers and shakers, as it were. Many of them were church leaders, and got the schools involved and pulled those people to whom other people responded. And it made a significant difference in increasing the vaccine rates in Baltimore City and increasing the awareness of this was not a joke. This was real and needed to be addressed, and you needed to think how you were going to address it. So I think we're all very aware of it. And sometimes I think it's more than just giving lip service. I think there's doing and actions that have to happen. Saying, yeah, I know this is what it is, but it can't be what it is. You need to one step further and take a step and act, as opposed to, as I say, just give lip service.
Absolutely. I agree 100% with each of you. I just want to highlight a few things that each of you said. One is this concept of intersectionality, which is extremely important. And, we know that if things are difficult for patients with PI, then they're even more difficult for patients with PI who may have one of these other identities, whether it's race, ethnicity, whether it's disability status, whether it's living in a rural area with poor access to care. So really understanding and highlighting that is important. I love the idea of these listening sessions, because one of the things that we know when working with marginalized communities is that they often have the solutions. They know what they need. And we sometimes in the medical industry, we come in as kind of the savior, so to speak, and we think that we know what these communities need. And I think certainly we've learned through COVID, and you brought this up, Dr. Younger, that we need to leverage the community and leverage those trusted voices, those community leaders, and really kind of work within their infrastructure and then provide the additional resources that are necessary. So I really appreciate that. And then lastly, Dr. Younger, you mentioned extra effort, and it just reminds me of the importance of highlighting the difference between equity and equality, and understanding that for some communities, it means that we do more. It means that we provide things differently in an effort to kind of level the playing field. So I appreciate all of those very important points. Well, we are wrapping up, and as we come to the end of this panel discussion, I want to talk about the future. So we've talked about where we started, we've talked about some of the challenges and the fact that the guidance needs to be global, but also needs to be very specific. We've talked about health inequities and best ways to address those. And so let's put our crystal ball, and we're looking now into the future. Where do you think we'll be a year from now? And what might that mean for people who are affected by a primary immunodeficiency? So we'll start with you, Dr. Younger.
Oh, thank you. I get the good hard question. When I talk to my people, I don't ever felt the need to beat them up about washing their hands, about wearing masks, about avoiding crowds. They were doing that from the day they were diagnosed. I don't send a kindergartner with X-linked agammaglobulinemia off to kindergarten without a bottle of Purell in his back jeans pocket. We've put together hand washing things for kindergarten classes for when my child is going to be, or one of my patients is going to be in that kindergarten class, to teach the other 5-year-olds about how important hand washing is, and blowing your nose into your Kleenex or into your sleeve. So my people get that education as part of their diagnosis. Okay, I know that I'm a little more susceptible to infections. What can I do? What can I do extra? So I've had conversations with people over the past 2 years. Do I need to beat you up? That yes, you probably can go to a concert, but do I want you in the mosh pit at the rock concert? Probably not. Do I want you in a bar that will comfortably seat 25 people with 6 deep at the bar? No, it's all about common sense, and it's all about risk benefits and analysis. And I'm not sure that's different. I just think it needs more emphasis. And that's what I do with my people. I say, they say, can I? And I can't give you the 100% do this, don't do this. You've got to consider what's best for you. And a once in a lifetime wedding where you're going to see family that you will maybe never see again. Yeah, I think you probably can safely go to that wedding if you think about what you're doing and how you're going to be doing it. I really think it's about conversations and about awareness and not right, not as you said, not edicts, but guidelines. These are the things I think you should think about. It's, when patients came in to me and said, well, I haven't been out of my apartment for 2 years. I haven't been to the supermarket. I haven't been to church. My first response is, and your mental health is what?
Yes.
And to me, that's terribly important. Is that a life living in your apartment for 2 years? Is that the life you want to lead? Well, if it's the life you think you need, then more power to you. But I'm not sure that's what's necessary. In this whole pandemic, the things that have gone to this wayside, not only mental health, but health maintenance. People haven't had mammograms for 2 years. Men haven't had their PSAs or prostates checked for 2 years. People haven't gotten their annual flu shot unless they got it in conjunction with the COVID vaccine. There's so many things to think about. I don't think we can be so tunnel visioned that pandemic is our life. I think it needs to be incorporated into our life. I'm certainly not advocating, whatever, let's just, la, la, la. I'm not talking about la, la, lying. I'm talking about putting it into focus and considering what impact it could have, it might possibly have, and what impact it does have. And I think that's what patients need to hear. And I think it's come home to me in terms of when patients have asked me, what do I think for 100 years of my practice? And I'm, whatever, blah, blah, blah. I think about that question more than I've ever thought about it. And I really try to couch my answers into, this is what I think, but it may not be what you think, and it may not be the right response for you, but these are the things that you need to think about when you're considering what your response should be. So maybe I have changed. Maybe I need to go back to the beginning of this and have changed over the past 2 years or 2.5 years. But that's what I think.
I love that. I really appreciate that you mentioned mental health, because that's something that we had not touched on. And you really can't have a panel discussion about COVID without talking about the vast implications for mental health and the restrictions that have been necessary but have absolutely impacted adults and children alike. So I really appreciate that perspective. What about you, Dr. Gundlapalli? What do you see in your crystal ball a year from now? Where will we be?
Well, I wish we had a crystal ball or a weather map that could help guide us. And so, the current thinking is on COVID is that the virus is tending towards or may have just become endemic and will be circulating at some level for at least the next year, right? I mean, you've seen the numbers go down. There's lots of testing that we don't have visibility on. So there will be some circulating. So, and variants will likely remain the concern going on for the next year. So we need to be monitoring closely for variants that have evolved to evade vaccines and immunity from prior infection. And we have to really continue to be able to put out the best guidance based on evidence and what we know, and honestly say this is what we know today. And so I think that would be it. And clearly, I think Dr. Younger's put it really well. Live life in a way that's compatible. Our patients with PI have always been on heightened alert. So this is one more sort of mega super heightened alert they have to be. But I think they will also, and they have also adapted really well. So that's really what it is. And to be aware with your provider about what's available for treatment and prophylaxis and vaccines. So that's where I'd leave it for that. Thank you. Over.
Thank you. That's great advice and recommendations. And I really love what you said about what we know today, because that's also been one of the biggest challenges with COVID-19 is that what we know today changes, and being flexible in that regard, and also being able to communicate with patients and families, both within the PI community and outside of the PI community, and helping individuals and families to understand that the guidance that we provided 2 weeks ago or a month ago may be different based on our new knowledge, based on new treatments and availability of other ways that we are mitigating this disease. Well, this has been a pleasure. I want to thank both of you. Thank you, Dr. Elizabeth Younger. Thank you, Dr. Adi Gunlapalli. You both have truly demonstrated your expertise, and I've really appreciated your view. And thank you for joining today, and I hope that you continue to. Oh, absolutely, absolutely. And thank you to all of you, and enjoy the rest of the conference. Take care.